I'll be introducing our teacher today, tonight's speaker, who is going to be taking us on antimicrobial stewardship for future healthcare professionals. And his name, which I have mentioned while praying, is Godwin Pius Ohemo. He is a policy-oriented antimicrobial resistance epidemiologist, a global health researcher who is dedicated to advancing public health through the One Health approach. He holds a bachelor's in technology in science laboratory technology and microbiology and a master's in epidemiology from the University of Port Harcourt. He also holds a postgraduate diploma in global health research from the University of Oxford and is currently pursuing a PhD in One Health Sciences at Texas Tech University, United States of America. And while serving as a graduate assistant at the AMR Knowledge Hub and Community of Practice of the Global Health Network, University of Oxford, he supported AMR research initiatives across Africa, Asia, Latin America, and the Caribbean. Mr. Godwin Ohemo Pius is a 2022 Foundation Moreau Fellow and is committed to strengthening stewardship, surveillance, and advocacy efforts to combat the challenges of AMR worldwide. So I would like you to give it up, send in your reactions as we invite Mr. Godwin Pius Ohemo to take the stage, even as he'll be teaching us this evening.
Right, thank you very much, Priscilla. I'm very, very grateful and glad to be on the call with you guys today. I really want to say that it is indeed a thing of great delight for me to be back on the call with the Antimicrobial Resistance Club at Babcock University. I know we did a lot of things together in 2025 and 2024 as well, and I'm so glad that 2026, I got the invite to come share my thought with you guys on the subject matter of antimicrobial stewardship for future healthcare professionals, and also to niche down on rational prescribing and culture and sensitivity testing. So for a lot of reasons, I'm very grateful, and I also very kindly want to say congratulations to those who convoked today. I learned that today is the convocation ceremony day at Babcock University, and I know so well that your former president or leader or coordinator, Dr. Emmanuel Wolabi, I believe, also graduated from Babcock University. To all those who made it through, congratulations, and I pray that this feat will bring you good luck and happiness. And may all that you decide to do moving forward, may it be blessed and favored immensely. So to start, I've been tasked with the responsibility to engage us in the conversation that you can see on your screen, antimicrobial stewardship for future professionals. So please, I'd like to confirm if you can see my screen clearly on your end before we start, or if I need to share again. Priscilla, please, can you confirm? Okay.
Yes, we can.
Okay, so the topic assigned to me is antimicrobial stewardship for future healthcare professionals, rational prescribing and culture and sensitivity testing. Looking at the topic very well, I can tell that the leaders or the leadership of the Antimicrobial Resistance Club at Babcock University actually want me to shed more light on how we can engage future healthcare professionals on what they need to know, the ins and outs of becoming a steward, becoming an antimicrobial steward, and how we can also guide them or enlighten them on rational prescribing, how we can help them see the need, for culture and sensitivity testing before the prescription of antibiotics or any antimicrobial for the treatment of any infectious disease. I personally do not want to just speak to future healthcare professionals. I really wish to speak to both future and current healthcare professionals. So just give me a sec. Let me stop this sharing and then try as much as I could to share it correctly such that you can see what I need you to see from your end. All right, so antimicrobial stewardship for future healthcare professionals. I decided to just play a little bit with what I was given. And instead of just speaking to future healthcare professionals, I want to speak to both future and current healthcare professionals, because on this call, most likely I have doctors on the call, I have nurses, pharmacists, microbiologists, lab technicians, lab managers, and primary healthcare workers. So this presentation is not just for those who are going to venture into becoming a healthcare professional in the nearest future, but as many who are already in the profession, who are frontline healthcare workers, and those who are administering treatment to patients. And I feel this is going to go a long way in helping us to have a broad conversation on the subject matter of antimicrobial stewardship. So, rational prescribing and culture and sensitivity, antimicrobial stewardship, not just for future healthcare professionals, but for the current ones and even for those who are aspiring to become healthcare professionals. I would like to start with this statement on your screen that antimicrobial stewardship does not start tomorrow, but rather it starts now, and it starts with you, and it starts right where you are. It is not a future responsibility that we need to leave for the government or for the policymakers. It is a present practice that everybody, all healthcare professionals, both the current ones, both those who are going to go, those who are going to enter into the profession in the nearest future, everybody needs to get involved. So I do not want us to look at antimicrobial stewardship from the standpoint of it being a future responsibility. I want us to see it as a present practice that we all can get involved in right now and right from where we all are. In essence, you do not need to be in Oxford in order for you to become an antimicrobial steward, or you need to be in Texas Tech University in order for you to be an antimicrobial steward. Right from your own little corner of the world, you can take measures, you can take steps that can help us to judiciously use antimicrobials prudently in our own setting, so that these drugs will be available for use for those who will need them in the nearest future, or probably tomorrow. So what is the current condition of antimicrobial resistance today? There will be no need for antimicrobial stewardship if there is nothing like antimicrobial resistance. And you all know that antimicrobial resistance, I do not see it as a disease. I see it as a phenomenon. I see it as a challenge whereby drugs that were originally designed to kill and to inhibit the growth and development of disease-causing organisms becomes ineffective due to the abuse, misuse, overuse, and underuse in different settings. So what is the current state of antimicrobial resistance today in our world? Based on available statistics, bacterial antimicrobial resistance directly caused 1.14 million deaths globally in 2021. And it was also linked to 4.71 million deaths in total that same year. If you look at the first few words that you have there on this statement, it said bacteria AMR. Why am I niching down on bacteria AMR? You know, when we talk about antimicrobial, it is not just about antibiotics, but more often than not, when we discuss antimicrobial resistance, we make reference to antibiotic resistance. But there are lots of other pharmaceutical products that fall under the umbrella of antimicrobial: antibiotics, antiparasites, antifungi, antivirus. All of these things put together are called antimicrobials, and they are used to treat infectious diseases and all of that. But among all of these disease-causing organisms like virus, bacteria, parasites, protozoa, and all of that, bacteria actually takes the lead in terms of the extent of the damage and the challenges that it caused. So in recent times, you get to see that when people talk about antimicrobial resistance, they make large reference to antibiotic resistance. The reason is not far-fetched from the fact that bacteria causes more harm, than virus does, and even than parasite also do. So bacteria AMR alone, now we are looking at bacteria AMR, directly caused 1.14 million deaths globally in 2021, and it was linked to 4.71 million deaths in total that same year. I want you to look at the figures on your screen carefully. 1.1 million deaths and 4.71 million deaths in 2021. This estimate is not an estimate of, of chickens. These numbers are real, and these are brothers and sisters of you and I. These are fellow human beings in different geographic locations of the world. This could be cancer patients, and this could be men or women who had cesarean section and they died due to the fact that they contracted a bacteria-resistant infection. So when we say that bacterial AMR caused 1.1 million deaths, I don't want you to just play with the numbers. I want you to relate with the number, engage with the number, and get to see the magnitude of the harm that drug-resistant bacterial infection is causing to our society. Antimicrobial resistance is also projected to cause 39.1 million deaths between 2025 and 2050. Look at it carefully. This is another projection. Now, in 2021, it caused 1.1 million deaths. Between 2025 and 2050, which is just 25 years interval, AMR is also projected to cause 39.1 million deaths. 39.1 million deaths. This could be the population of like 2 nations put together, and they will be lost due to drug-resistant bacterial infection. The figures are staggering, and loss of lives are being lost. Years of medical advances are being compromised due to the emergence and spread of drug-resistant bacterial infection. And it is a thing that we all should be concerned about. But the good news that I have for you and for myself this evening or this afternoon or this morning, depending on the time zone in your location, is that better healthcare access and appropriate antibiotic use could save 92 million lives between 2025 and 2050. And this is where you come in as a healthcare professional, whether you are a current or you are a future healthcare professional. The study that estimated that antimicrobial resistance, or the study that reported that bacterial AMR directly caused 1.14 million deaths in 2021, and also the one that estimated that AMR is projected to cause 39.1 million deaths between 2025 and 2050, also state that if there is better healthcare access, and if we use antibiotics prudently in various settings, in healthcare practice, in animal husbandry, in the environment, and all of that, he said we could save 92 million lives between 2025 and 2050. Looking at the figures on your screen carefully, I know so well that you would tilt towards the last one, which is better healthcare access and appropriate antibiotic use could save 92 million lives between 2025 and 2050. We cannot sit down and fold our hands and watch 39 million brothers and sisters and fellow human beings in different geographic locations to die due to drug-resistant bacterial infection. We can do something, and a few of the things that we can do is better access to healthcare, appropriate antibiotic use, which is stewardship, and this is estimated to save 92 million lives between 2025 and 2050. So the question before you and me this evening is, what is antimicrobial stewardship and why should I care? Why should you care as an early career researcher? Why should you care as a senior career researcher or a mid-career researcher? Why should you care as somebody who is aspiring, to become a healthcare professional? Maybe you aspire to become a nurse, to become a doctor, to become a pharmacist, a microbiologist, a med lab scientist, irrespective of that which you want to venture into, as long as you fall under the umbrella of healthcare profession. I feel there is something that you should be aware of, that borders around antimicrobial stewardship. So what is antimicrobial stewardship and why should I care? There are lots of there are lots of definition as per what antimicrobial stewardship actually is. According to the World Health Organization in 2019, the WHO defined stewardship as a coherent set of actions that promote the responsible use of antimicrobials. Now, in this case, they didn't say that promote the responsible use of antibiotics. They are looking at it holistically because antimicrobials is not just about antibiotics. It is about antibiotics. It is about antiparasitic. It is about antivirus. It's about antifungi and all of that. So the household name for all of these pharmaceutical products is called antimicrobials. And the coherent set of actions that promote the responsible use of this pharmaceutical product is called stewardship. That is according to the World Health Organization. Number two, according to the Infectious Disease Society of America and the Society for Healthcare Epidemiology of America, in 2007, they defined stewardship as a set of coordinated strategies to improve and measure the appropriate use of antimicrobials by promoting the selection of the optimal drug regimen, including dosing, duration of therapy, and route of administration. It is a set of coordinated strategies. It is not just one step, right? It is a combination, like a coordination of activities to improve and to measure the appropriate and the judicious use of antimicrobials by promoting the selection of the optimal drug regimen, including dosing, duration of therapy, and route of administration. And then finally, the third definition that I want to share with you today is the definition of the United States Center for Disease Control and Prevention. This definition is made available on their platform in 2026, and it says that stewardship is the effort to ensure that antibiotics are prescribed and used when they provide a clear health benefit. While the US CDC is talking about antibiotics, the Infectious Disease Society of America and the Society for Healthcare Epidemiology of America, they talk about antimicrobials. The World Health Organization talks about antimicrobials. That is the combination of antibiotics, antiparasites, antifungi, antivirus, and all of that. So stewardship, touches on the coherent set of actions that promote responsible use of antimicrobials and even antibiotics as well. So these are the definitions. And if you look at this definition carefully, one thing that is unique is that it is not a single step. Stewardship is a set of actions. Stewardship is a set of coordinated strategies, okay? It is a set of effort to ensure that antimicrobials are used and that they are prescribed when they provide a clear health benefit. So to you and to me, what exactly is antimicrobial stewardship? Now, we've looked at the definition of the WHO, the Infectious Disease Society of America, and that of the United States Center for Disease Control and Prevention. But let's bring it down to ourselves. What do we think antimicrobial stewardship is all about? I would like to hear from you so that it doesn't look as though I'm just doing the talking. I just want one or two persons volunteer yourself, unmute your mic, and then just share with me what you think based on your own understanding. What do you think antimicrobial stewardship is all about? Anybody? Priscilla, please go ahead.
Okay, so I think antimicrobial stewardship is a set of like mindful actions taken to not just for yourself but for people around you to educate and to ensure that antimicrobials are used responsibly, not just by yourself but also by the people around you.
Thank you. I like the word that antimicrobials are used responsibly. That's very correct. Thank you so much. Any other person on the call who would love to give us his or her definition of what antimicrobial stewardship is? Lawrence, are you on the call? Can you help us out with your definition?
So I'm here, sir. Yeah, I feel like antimicrobial stewardship is not just a term that encompasses only those in the medical field. It encompasses yes, those in the medical field, correct, but also even the people that don't understand what antimicrobials actually are. So it explains the correct use of antimicrobials and the way that each of us, even those that are not well versed in that area, are supposed to use the antimicrobials, and the way those of us that are well versed are supposed to administer and also ensure that antimicrobials are properly used.
Awesome. That's nice. Thank you so much. Antimicrobials are properly used, not just in the medical field, not just in healthcare, but also in human health, in animal health, in plants and the environment, and even in the food and agricultural sector as well. Antibiotics and other stuff are being used as well. So thank you guys for the definition you've given. Those were very, very brilliant and straight to the point. Now, according to me, I feel antimicrobials or antimicrobial stewardship can be defined as the judicious and appropriate use of antimicrobials. Now, within the human health sector, within medical practice, antimicrobial stewardship is the judicious and appropriate use of antimicrobials, ensuring the right patient, ensuring the right drug, the right dose, the right route, the right duration, not just once in a time, but every time. And the reason for doing this is to preserve the effectiveness of antimicrobials. So let me say it again. Antimicrobial stewardship is the judicious, it is the appropriate, it is the careful and the mindful and effective use of antimicrobials to ensure that these antimicrobials are given to the right patient, the right drug is given to the right patient, and the right dose of the drug is given to the patient, and the patient takes the drug via the right route. It takes it for the right period of time, and it is done every time for every patient that drugs are being prescribed to, and this is done so as to preserve the effectiveness of antimicrobials. So this is what I think antimicrobial stewardship is all about. It is the careful and the responsible and the appropriate use of antimicrobials, be it antibiotics, be it anti-parasite, antifungal, antivirus, be it in human health, in animal health, in plants and in the environment, in agriculture and in food system. Antimicrobials must be used prudently. They must be used judiciously. They must be used appropriately. And the essence of doing this is to ensure that we preserve the effectiveness of this drug, not just for ourselves, as Priscilla said, but also for other people who might, become ill tomorrow and they might need these antimicrobials for the treatment of the infection that they are suffering from. So this is what I think antimicrobial stewardship is all about. But then there's no way you can talk about antimicrobial stewardship without talking about the 5 rights. The 5 rights, like the 5 right things that we must do as we yearn to become stewards of these wonder drugs that we have for the treatment of infection that are caused by different microorganisms. So what are the 5 rights? The first one is that good stewardship begins with the right patient. And why is this very, very important? Let's assume you are a pharmacist and a patient comes to you and it comes with a test, it comes with a doctor's prescription. That patient, the drug that we're about to administer must be given to the right patient. If you give the right drug to the wrong patient, you are not being a careful steward of antimicrobials. Antimicrobial stewardship begins with the right patient. Is this the patient that is ill? Are you the one that is suffering from this particular infection? Did you go to the lab for this particular diagnostics? Were your samples collected, be it blood sample, urine sample, stool sample, or sputum sample? Were your samples collected? What is your name? Does the name that the patient called for you tally with the name that we have on probably the lab result or the one that you have on the doctor's prescription list? It is very, very important. So becoming a steward begins with we as healthcare professionals making sure that drugs are prescribed to the right patient, that drugs are administered to the right patient. If you administer or you prescribe the right drug for the wrong patient, you are making a very serious mistake, and that shouldn't be the case. So it begins with the right patient. Then number two, the right patient needs to get the right drug. So that is the second right. Now, when we talk about the right drug, we are talking about, does the drug that you're about to give to the patient, does it match the pathogen or the disease-causing organism that is responsible for this disease or for this infection or health condition that this patient is down with? It's not proper for a patient to be down with a parasitic infection, or of course to be down with a parasitic infection, and you are prescribing antibiotics, or you're administering antibiotics to that patient. Antibiotics are designed for bacteria only infection. Antiparasite are designed for parasite only infection. Antifungi for fungi only infection, and antivirus for virus only infection. So we need to make sure that the right drug is given to the right patient. This patient is down with a bacterial infection, probably Staph aureus or E. coli infection, okay, and lab results have confirmed this. Therefore, take these antibiotics, take amoxicillin. That is right patient with the right drug. Then the next thing is, now that we know the right patient and we have administered the right drug, we have confirmed that this drug match the disease-causing organism in the patient, then what is the next thing to do? The right dose. The right dose based on the weight, based on the organ function, and based on the site of infection. Okay, this is the quantity or the dosage of the drug that you are supposed to take. Even if you have the right patient, even if you have the right drug, and you give the wrong dose to the right patient and all of that, it's not going to work, because you are not administering your care as a steward who is very much aware that the right drug works very, very well with the right dosage. There is a quantity that you must administer in order for it to be able to kill or to inhibit the growth and the development of the disease-causing organism in that patient that is before you for attention. Then after that, we must look at the right route. The right route. How should this drug be administered? Should we administer the drug via oral route? Should we administer it via IV or via IM? For those of us who may not be in the medical field, or who are not medical doctors or nurses, just like myself, oral route simply means, is the patient going to swallow it via the mouth? IV, it means that is the drug going to be injected via the vein of the patient? IM, are we going to inject the patient via the muzzle and all of that? So right drug, right dose, right patient, right route. If there is a drug that you are supposed to take via IV and you are taking it via oral route, you're actually abusing that drug. You are not coming across as someone who is a good steward of the wonder drugs that we have available at our disposal. Now, the fifth thing that I want to talk about, which makes the 5 rights of antimicrobial stewardship, is right duration, effective duration. How long should the patient take this drug? For a day, or for 3 days, or like, what is the time frame for this drug to be taken? Because the right patient, the right drug, the right dose, the right route must be taken for a period of time, for the specified period of time, in order for it to be able to work effectively. So if we have the right duration, it's going to cut down on unnecessary prolongment of time. Drug that you ought to have taken for 3 times, you are taking it for 7 days. You're actually subjecting your body to unnecessary dose of antimicrobials, and unconsciously you are contributing to the rise or to the selective pressure that comes from the fact that you are using this drug out of the period of time that you ought to use them. So my dear colleagues, on your screen is the 5 rights of antimicrobial stewardship. Right patient, right drug, right dose, right route, right duration. This is not just applicable to being an antimicrobial steward, but also every prescribing decision that is made every time hinge on these 5 major steps. I have the right to stop here and say we are done with the lesson on antimicrobial stewardship, but I just don't want to just give you these 5 rights and then I step aside. I looked at it carefully, and I also found that in addition to these 5, I think there is one that is missing. So on my own, I decided to add number 6, which is right time. Because if you have the right patient with the right drug, the right dose, the right route, and the right duration, and the patient is not taking the drug according to the right time, the patient is not being consistent with dosing interval, the patient is not aware whether he or she should take the drug before meal, after meal, or without meal, and he just went ahead and he's just consuming the drug, it may not actually work effectively, because there are some drugs that work better on empty stomach, and there are drugs that work well when you have taken in food in your system. So there is need for us to add the right time and to make it the 6 rights of antimicrobial stewardship. If you want to become a steward in your own locality as a custodian of the wonder drugs that we have available at our disposal, always watch out for the patient that you are actually administering drug to. Is this the right patient? Do the confirmation. Am I giving the right drug, the drug that match the causative organism for the infection that the patient is down with? Take note of that. Am I giving the appropriate dose based on the weight, based on the organ function, based on the site of infection? Am I also telling my patient that am I guiding my patient on the right route via which this drug should be taken? Oral route, IM, and IV. And then right duration. How long, effective duration, how long is my patient going to take this drug? And finally, the right time. Consistent dosing intervals before, with, or without meal or after meal. This information are very, very important. So why should I care as a current or as an aspiring healthcare professional, given the fact that we've looked at these 6 rights? The truth of the matter is, my dear colleagues, if you get these 6 steps right, you save 2 patients. You save the one that you are treating and the one who will need this drug to still work tomorrow. If you get these 6 steps right, you save 2 patients. You save the one that you are treating at the moment and the one who will need this drug to still work tomorrow. And the one who might need this drug to still work tomorrow might be your sibling, might be your loved one, might be someone who is so dear to you. And even if it's not your sibling or your parent or your loved ones, please, antibiotics, antimicrobials are wonder drugs that we have. They are the only option that we have to treat infection or to treat illnesses. If you abuse them and you force the bacteria or the parasite or the virus or the fungi to develop resistance to the potent effect of this drug, it's more like you have rendered us powerless, to ward off the threat that is being posed by drug resistant infection in different settings. So get these systems right and you save 2 patients. You save the one you are treating and the one who will need this drug to still work tomorrow. I want to talk briefly on diagnostic stewardship and antimicrobial stewardship, because the both of them work hand in hand. There's no how I can talk about antimicrobial stewardship without touching briefly on diagnostic stewardship, because you can't just be a steward of antimicrobials and you are not a good steward when it comes to laboratory investigation and all of that. So diagnostic stewardship and antimicrobial stewardship, they work hand in hand. So as you can see from the chart on your screen, the first step is that a patient is evaluated for symptoms. What exactly is wrong with you? How do you feel? What are the symptoms that you are feeling? What signs are there? And then what can I see, like as a doctor, what can you see based on clear observation? So based on the history that the patient will account to you, and based on the symptoms that the patient will present with, and based on the things that you can see, you can then say, okay, I'm going to ask for this diagnostic test. I'm going to ask for CNS. I'm going to ask for culture and sensitivity test, okay? And I will send this to the lab and ask the microbiologist or the med lab scientist in the lab to collect your sample, right? To collect your sample, maybe your blood sample, your urine sample, stool sample, your sputum sample, or whatsoever, any kind of sample that you want that can help the doctor to be able to tell or that can help the microbiologist or the lab staff to be able to tell this is the causative organism that is currently present in your body, okay? And this is what we think, will be the right thing to do. So patient is evaluated for symptoms based on what the doctor sees, and based on the prognosis, the doctor can say, okay, let's do diagnostic test. Let's order for culture and sensitivity. Now, it takes 48 hours to 72 hours for a normal culture, for a culture result to be ready. In cases whereby the patient is severely ill and the patient is about to die, for instance, the doctor cannot keep waiting for the next 72 hours, to administer treatment to the patient. So what is he going to do? He's going to switch to what we call empirical antibiotics. And these are broad spectrum antibiotics that are actually given to patients that are, severely ill and their life is on the line and something needs to be done. Like we need to protect the patients from dying immediately. Okay, so empiric antibiotics are broad spectrum antibiotics that are given to patients based on the good guess that the doctor has made. Okay, I think based on my experience and based on my observation and based on my training and based on the history of cases that I have handled, I think while we wait for lab result to come, you should be on these antibiotics. And these antibiotics are not narrow target, they are broad spectrum. In other words, they go there to kill anything that is likely to be responsible for the condition that you are down with. So if the situation is severe, the doctor will have to subject you to empiric antibiotics immediately. But if it is not severe, for instance, like you look at the patient is still healthy, is still strong, the patient can still hold on a bit for the next 72 hours before CNS is ready, then we can do what we call watchful waiting. Just keep the patient under close observation. Or better still, we can choose to give the patient more supportive care up until when the lab result is ready and the doctor can say, okay, clearly, this is what the problem is, and this is the narrow spectrum of antibiotics that is necessary to treat your infection. Now, when the lab result is out, the doctor have to de-escalate or to stop. To de-escalate simply means, okay, we place you on a broad spectrum antibiotics initially. We made a wide guess. And now that the result is out, we discover that this is not the antibiotic you are supposed to be placed on. So we are going to de-escalate. We are going to stop these antibiotics and place you on a narrow spectrum antibiotics that is designed to kill and to inhibit the specific causative organism that is responsible for the situation that you are down with. So there is a need for the doctor to modify the therapy or the treatment that you've been given. We have the right to jump from diagnostic testing, and then go and then like no need for modifying therapy if we do watchful waiting or supportive care. But in cases of life-threatening situation, empiric antibiotics needs to be given immediately to sustain the life of the patient. Now, let's look at the diagnostic steward aspect of what is on your screen. Ordering, clinical context, and risk factors. The doctor asks you questions, what exactly is wrong with you, and based on what you tell him or her, based on the history that you account and the symptom that you present with, the doctor can order ACS, can order for some lab result or for some lab tests, and that will be carried out on you. And based on the lab request that the doctor gives to you, you go to the lab, the microbiology lab or the hospital lab of that the lab of the hospital where you are at the moment, and then they collect your sample. They collect your blood sample and all of that. And diagnostic steward calls for the collection of sample to be done under clean condition to avoid contamination. Okay, so clean condition, good sample collection, and proper labeling. More often than not, we don't take labeling as important. And we've had cases whereby some people actually were pronounced to have a particular disease that was not the result that was meant for them. So good stewardship, good diagnostic stewardship calls for great care The lab staff must be very, very careful to make sure that the samples are collected under clean and contamination-free environment using free available techniques, and make sure that the sample bottles are labeled accordingly, either with the codes or with the name of the patient, so that there is no misplacement of result or giving the result that was meant for Mr. A to another to Mr. B and vice versa. Very, very important. When the result is out, there is reporting. The lab technician has to report the result, report true infection versus colonization, report what you see. Like you should have been trained, like you know what to report, and you don't just report in a way that you even end up confusing, the pharmacists or confusing the doctors who are also going to interpret what you're talking about. Report it the way it is. We saw that this person have staph infection, and then we did culture and sensitivity, and we saw that the staph or the causative organism that is responsible for this patient infection is resistant to amoxicillin, but is susceptible to this, and that. And then the doctor knows, okay, if the organism is resistant to amoxicillin and is susceptible to, let's say, ampicillin or whatsoever, the doctor knows the right one to give to you so that your illness can be well catered for. Antimicrobial stewardship in the last arm, calls for doing the 6 things that we have talked about: the right patient, the right drug, the right dose, the right route, the right duration, and the right time. And then after you must have, gotten lab result, you have to de-escalate, modify from broad spectrum to narrow spectrum after you have gotten culture and sensitivity test. And then finally, antibiotic timeout. What is the timeout? We have the result now, and the result shows this and that. Now we have placed you on an antibiotic that we think, based on our wide guess, that could help to keep you alive up until when CNS is out. We have discovered that this is what is responsible for it. Therefore, we have to stop this other one we've been giving to you before, and then place you on this one that is the right one, for you to do. So antibiotic timeout is very, very important, because once the result is out, the doctor must go back and look at the screen. Okay, we give him this. This is not the right antibiotic for this particular treatment. But where the problem comes is that when the lab result is out, you fail to check whether the particular antibiotic you gave to the patient is the right one, and you allow the patient to keep consuming inappropriate antibiotic for a wrong infection. You are not being a very good steward. So if life-threatening infection, empiric therapy is a necessary first response. It should be started immediately, because delay could cost life. And if the patient is stable, we should consider watchful waiting or supportive care before defaulting to antibiotics, and let culture and sensitivity result guide the next step. Let's look at the difference between antimicrobial stewardship and diagnostic stewardship. Is there any difference at all? I'd like to talk about this, under a couple of reasons that you can see on your screen. We look at the goal, we look at the core question that each of these arms actually asks, we look at the key actions, we look at the timing rule, and then we look at, your role as a professional, as a healthcare professional. Now, for the first one, antimicrobial stewardship, the goal is to preserve antimicrobial effectiveness. For diagnostic stewardship, the goal is to ensure accurate and timely diagnostics, like diagnosis, right? Accurate and timely diagnosis, very important. Now, the core question that antimicrobial stewardship asks is this the right patient? Am I giving the right drug? Is this the right dose? Is this the right route? Is this for the right duration? And then have I told the patient whether to take it, when to take it? Is it before bed or very early in the morning, with meal, without meal, before meal or after meal? Very, very important. But then diagnostic stewardship asks the question, do we have the right information to decide on what antibiotic exactly to place this patient on? These are very, very important. Then the key actions that can be taken for antimicrobial stewardship is we have to de-escalate, or we have to escalate, or we have to discontinue or continue after culture and sensitivity result is out. Antibiotic timeout between 48 and 72 hours is extremely important. There's no reason for a patient to continue on an antibiotic that you placed him or her on based on empiric, consideration when you have the result of C&S already out and it tells you, to look at another option. You should actually review what you've done and then make appropriate amendments as soon as possible. For diagnostic stewardship, you need to order the right test. Order the right test. Clean specimen collection, distinguish true infection from minor colonization. And then the timing rule for antimicrobial stewardship is if it is immediate, you need to administer empiric treatment immediately if it is life-threatening, or better still, you can do watchful waiting or supportive care if the patient is stable. On diagnostic arm, you need to send for C&S before or alongside empiric therapy and never delay treatment because life is on the line. Now, your role as a healthcare professional under antimicrobial stewardship, you need to ask the very, very nice question. Have we de-escalated yet? Or the patient is still on the antibiotics that will place him on empiric kind of the wide guess that we made. Now that C&S is out, have we de-escalated? And then for diagnostic stewardship, for the lab technicians and the med lab scientists on the call, you need to ask the question, was a culture sent before antibiotic actually started? These are extremely important. Now, I want to talk about, in addition to what I've said so far, the 4 moments of antibiotic decision making. There are 4 major moments, that we need to make decisions as per using antibiotics or using antimicrobials. I told us earlier that based on the extent to which bacteria causes infection, we often tilt towards bacterial infection or antibiotic when we discuss antimicrobial resistance. But the 4 moments of antimicrobial decision making or antibiotic decision making are what you have on your screen. The first one is make the diagnosis. And to do this, you must ask yourself, does my patient have an infection that requires antimicrobial treatment? Before you initiate antibiotic therapy, it is important to review all clinical, all laboratory and imaging data, and then weigh the potential benefit versus harm of initiating empiric therapy. Very, very important. Make the diagnosis, right? Does my patient have an infection that requires antimicrobial treatment? Number 2, culture and empiric therapy. Have I ordered the appropriate culture? What empiric therapy should I initiate? Number 3, stop, narrow, change to oral, or change to IV, or change to IM. Every day after initiation, can I stop antibiotic treatment? Can I move from broad spectrum to narrow spectrum? Can I switch to oral routes? These are, questions that you need to ask yourself as someone who is steward-minded, who is trying to make sure that antimicrobials are used prudently and appropriately for the treatment of bacteria or for the treatment of infectious diseases. Then number 4, duration. Determine the duration of treatment. Once the definitive diagnosis is established, determine the shortest antibiotic duration known to be effective. It is important for you to document the planned initiation dates, duration, and stop dates in the medical record. Extremely important, and I'm confident that medical professionals on the call will also attest to the fact that this is the right thing for you to do as antimicrobial steward. I'd like to speak quickly, for time's sake, on the 5 pillars of effective antimicrobial stewardship. What do I do? How do we, make sure that antimicrobials are governed? How do we make sure that they are well protected and guided? Because as these drugs are failing, microbes are evolving. They are every day, as day breaks and night falls, they are developing resistance to the potent effect of antimicrobials. And if we don't have antimicrobials to treat infection, then we are powerless. Woe betide us if we don't have any tools and equipment to be able to mitigate the rise and spread of drug-resistant bacterial infection. So for me, I believe that antimicrobial stewardship is not just a thing for the government. I see it as a whole of government and a whole of society issue, society idea, and it runs through you and it runs through me. I have a role to play and you have a role to play. And that role hinges on how effective and how prudent and judicious you use antimicrobials in your various settings. So the first pillar of effective antimicrobial stewardship is this: workforce capacity development. If there are no trained hands, there can be no steward. If we are not exposed to the requisite information that we need in order for us to be able to administer drugs to the right patient, the right drug, the right route, the right time, the right duration, if we don't have the workforce, if there are no pharmacists, there are no nurses, no doctors, no lab scientists, no lab technician, no lab staff, you cannot succeed in making sure that antimicrobials are guided judiciously. No trained hands, there can be no steward. And one of the reasons we have issues of AMR in different settings, particularly in low resource setting, is a function of the fact that quacks are the ones who are actually doing what they are doing in one small cubicle. They call it a lab, and they are running what they are running and releasing what they are releasing. We need workforce capacity development. People need to be trained adequately, prepared, and equipped with the requisite tools and knowledge in order for them to be able to make sound and intelligent decisions to preserve the effectiveness of antimicrobials. Number two, awareness and education. No awareness, there can be no behavior change. We need to raise awareness. And I'm very grateful to the AMR Club of Babcock University for putting up this initiative where we can come together to enlighten ourselves on the subject matter of antimicrobial stewardship. Today, you must have learned what antimicrobial stewardship is, and you must have been challenged within you to become a steward, to become a guardian of these wonder drugs that we have for the treatment of infection, whether in human health, in animal health, in plant and the environment, in agriculture, and even in food system. We must raise awareness. In our place of worship, let us raise the awareness about antimicrobial resistance. In our place of study, let us raise awareness about the challenges of antimicrobial resistance. It is estimated that 39.1 million people are likely to die between 2025 and 2050 due to drug-resistant bacterial infection. You don't need to wait until it happens to you or to your loved one before you swing into action about raising awareness and guiding them on how best to use antimicrobials prudently in their own setting. Awareness and education is very important. In your family, when you have dinner, when you gather for family conversation, bring up the subject matter of antimicrobials, antimicrobial resistance. Enlighten your dad, your mom, your siblings, your wife, your husband, your children on how to use antibiotics and antimicrobials prudently in their various settings. It helps. You don't want your family or your loved ones to be in that number among the 39.1 million individuals that we are talking about. Number three, governance and enforcement. This is very, very important. Nothing actually works. No stewardship can be effective when there is no governance and enforcement. And I have a reason for saying this, because it's not enough for you to promulgate laws, rules, and regulations. Those laws, those rules and regulations must be backed up with enforcement. There is need for legislation, and there is need for punishment for those who violate the already established rules and guidelines. In our country, in LMIC, you can walk into any pharmaceutical store and buy as many quantity of antibiotics that you want, as long as you have the money available at your disposal. It shouldn't be. Here in the United States, where I am right now, I can tell you confidently that I cannot walk into a pharmacy store and tell the pharmacist and say, I feel I have an E. coli infection. I feel some itching, on my lower parts and all of that, and I need you to give me amoxicillin or give me ampiclos or give me clozacillin and the rest. The question the pharmacist will ask you is, do you have your prescription? Do you have your doctor's prescription? If you say yes, you do, they collect it from you and they compare what you're giving to them to what they have, the record they have on their system. Because when the doctor sent a prescription, it's not just to you alone, they also sent it to the pharmacy, like which location are you, which pharmacy is closest to you. You give the address, they look at the map and they pick that particular store and they send the prescription to them. So when you get to the store, you just say, I want to get my drugs. And they tell you, do you have a prescription? You say, yeah. Say, what is your name? You tell them your name. You tell them your date of birth. They enter it on the system and they see, okay, your doctor requests for this. And then they give it to you. Because the pharmacies, the system trusts that the prescription must come from the doctor to the pharmacist and then to you. And the pharmacist gives it to you. And based on their training, they tell you, okay, take this 3 times a day, or 1 in the morning or 1 in the night, and they take it for 7 days, take it for 14 days. If at the end of the 14th day, the drug is still remaining, discard it. And this is how to discard it. In fact, some even have a collection center where you go to discard your unused antibiotic, like unused antimicrobials. This is governance and enforcement. It is working. When I was in the UK, I went to the store as well, and I asked the question. I was feeling some pain all over, and then I was like, okay, now man, I'm in the UK and I'm going to go back shortly. Let me, get as many antibiotics that I can get, and maybe I'll be able to use them when I get back to my country. I went to the pharmacy store and I engaged the pharmacist. One thing she did that amazed me was that she listened to my analysis. Like, she listened to me carefully from beginning to the end. I told my tales. I wanted to convince her I had the money to buy the drug. Then I said, can I have ampiclos? Can I have amoxicillin? And she was like, do you have your prescription? I said, I don't have a doctor. Every patient needs to be under a doctor. And it's your doctor that actually sent your prescription. She didn't give me anything. The only good she did for me was that she asked me, how severe is the pain? She was like, I said, I can't walk properly. She said, okay, here's what I can do for you. I'll give you paracetamol. And I was like, all the story that I've been telling you since morning, the only thing you can give to me is paracetamol. I had no choice but to buy 2 packs of paracetamol, pain relief. She gave it to me so I could go home and use it. And if symptom persists after a couple of times, I should make sure I get access to my doctor. Governance and enforcement is very important. When there is no accountability and no consistency, nothing is going to work. Number 4, diagnostic infrastructure. There cannot be effective antimicrobial stewardship when we don't have labs that are functioning, when we don't have labs that are equipped with trained med lab scientists, trained microbiologists, trained individuals who knows what they are doing. Infrastructure, very, 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 very important. And then finally, finance and investment. Government have to invest. Organizations have to invest in making sure that stewardship is not just what we have on paper, but something that is in reality. When there is no funding, there's no system that can actually sustain it. So finally, my dear colleagues, how can you help as a healthcare professional, as a current healthcare professional, as a future healthcare professional? For those of you who convoked today, congratulations to you. But the big question I have for you is, how can you help? How can you help in the area of making sure that the wonder drugs that we have out there are used judiciously? How can you help? What can you do? There are 6 things that I feel you can do. Number 1, apply the 6 rights. Apply the 6 rights at every prescription, at every time. Make sure that the drug that you are administering is for the right patient. Make sure that the drug is the right drug for the right pathogenic organism that is responsible for that infection that the patient is down with. Not just for a week, not just for a moment, but these 6 rights must be applied every time. Every time prescription is being done, this is the phase that we must follow. We must champion diagnostic stewardship. We must learn to order rights. We must learn to collect clean, and we must learn to read critically. Lab technicians, med lab scientists, very, very important. Nurses, midwives, everybody that is under the umbrella of healthcare profession champion diagnostic stewardship. Number 3, own the antibiotic timeout. The patient has been on this drug for a period of time empirically without lab investigation. Now the lab result is out. Is the patient still on that drug? And is that drug the right drug that the patient is supposed to be on? The one that you place the patient on based on your wide guess, if it shows that it's not the right one, de-escalate. Stop that patient from that and then place the patient on the right one that is supposed to be. I always ask that question, have we de-escalated yet? Judge severity and not habit. Know when to wait and know when not to wait. Know when to wait and know when not to wait. When life is on the line, when the patient is critically ill and the patient can no longer wait for 48 to 72 hours for C&S to be available, switch to empiric antibiotics. But when C&S result is out, be a good steward. Review what you've done before, and if it is not the right thing that you should have done, please de-escalate and place the patient on the narrow spectrum antibiotics that will help the patient to get healed. Now, educate every patient. No antibiotic today can be a good care too. It's not every sickness that the patient comes, you give antibiotics. Sometimes what is wrong with some persons is that they need good sleep. Sometimes they are stressed and overwhelmed. Sometimes they need supportive care. So it's not every particular, I'm feeling some pain here, you administer antibiotic. No, you have to be prudent, you have to be judicious, you have to be appropriate in your administration. No antibiotic today can be a good care as well. And finally, advocate beyond the bedside. Of course, as healthcare professionals, you do consultation by the bedside, you do counseling by the bedside, you do advising by the bedside. But I want you to advocate beyond the bedside for labs, for funding, and for policy. Even people who are in your immediate household, in your church, in your mosque, in your religious centers, in your town hall meeting, when you gather in your village town hall for conversation, enlighten the farmers, enlighten the animal rearers on how to use antibiotics prudently. Because more often than not, the advocacy that we are championing is more like from the senior colleagues up there to those who are aspiring. Hardly do you see farmers, the common farmers or the ordinary farmers on Zoom calls. As we are speaking here, I don't think we have a farmer from a rural area somewhere in Ogun State in Nigeria who is on this call to understand what antimicrobial stewardship is all about. We need to take our advocacy beyond the bedside, beyond Zoom call, beyond WhatsApp conversation, and take it down to those who are in the rural area. Each enlighten the other person at the lower cadre. Grassroots advocacy, for me, I think it yields more result than the well-exposed professionals engaging the emerging professionals on Zoom call, and everything is just going in a circle. We must branch out, we must reach out to religious leaders, to poultry farmers, to pig owners, to goat rearers, to cattle rearers. These are areas where drug-resistant bacteria are actually emanating from, and we cannot correct this anomaly if we keep following the trend that we have been practicing for a very, very long time. So, my dear colleague, antimicrobial stewardship starts now with you. It's not a future project. It starts now with you right from where you are. It is not a future responsibility. It is a present practice, and everybody must get involved. Antimicrobial resistance is built one unnecessary prescription at a time. Antimicrobial resistance is built one unnecessary prescription at a time. And antimicrobial stewardship is built one thoughtful decision at a time. Let me say it again. Antimicrobial stewardship is built one thoughtful decision at a time. And the future depends on which one you choose and on which one I choose. I pray you choose one thoughtful decision for just one patient. Because if you take good care of one patient and you use the 6 rights, and in your profession, in your practice, you judiciously, you carefully and appropriately use antimicrobials for the right patient, the right drug, the right route, the right duration, the right time, you will not only save the patient in front of you, but also give the other patient who will come before you, who will come to your facility tomorrow, the opportunity to have access to antimicrobials that could be used to treat the infection that the patient is down with. I really want to thank you very much for the opportunity you've given to me and for being so attentive to my presentation. I'm grateful, and I hope I have probably in a way challenge you to look at stewardship from the standpoint of um, right drug, right duration, and all of that. But look at it from the standpoint of the six rights. Okay, particularly look at the timing, look at the patient. Is this the right patient for this stuff? And I feel as we all continue to do our best, we'll be able to contribute our own quota, to making that thoughtful decision that will help us to preserve the effectiveness of antimicrobials that we have available at our disposal. Thank you so very, very much for having me on the call. I'm grateful. And if you have any question, I'll be happy to lend my voice on that. And feel free to connect and let us collaborate together, because collaboration is the way. Nobody should work in silos. We need each other to be able to ward off the challenge that is being posed by drug-resistant bacterial infection in different settings. My name is Godwin, and it's been a great delight speaking to you on the subject matter. Thank you very much.
Thank you so, so much, Mr. Godwin Pius. We are so very grateful. It's been a wonderful time. I have learned so much, and I believe that everyone who joined this call has learned a lot as well. I have been greatly impacted, especially the difference between antimicrobial stewardship and diagnostic stewardship. That is such a wonderful like description, and we are really grateful to have you here with us, sir. I
Thank you.
would thank you. Please send in your reactions, send in your messages, say thank you. And if you have any questions too, you can unmute yourselves to ask your questions. And very importantly, I would also like to recognize the presence of uh, Professor Charles Eliku. He has been with us for a while. He is our patron at the AMR Club. He's like a father figure to us. The HOD of medical microbiology is my teacher. Is such a wonderful man. We are glad to have you here, sir. You're welcome. Oh, sir, you are raising your hand. You
Thank
can
you.
unmute.
Yeah, thank you, Priscilla. So I quickly raise my hand so that I can start. We've been together since 2 hours ago now. So I needed to do something. But OJ has tweeted that I joined this, and I'm glad I did. So first of all,
Thank you so much.
I want to appreciate the speaker of today, uh, Godwin Pius. Am I right?
Yes, sir, you're
That's
right.
Dr. Godwin, yes. So it was a nice time meeting you, and I'm happy at the quality of the engagement that the AMR Club has really engaged you with
Thank
all
you.
of them. So it's really a great one for me. I appreciate the leadership of the AMR Club of Babcock University. So I totally agree with all that you have said, and I also appreciate because you have really what you have presented. I believe is also like a stimulant to the webinar we had like an hour before your home.
Okay.
So, but not everything that you start talking about research now, but
Yeah.
it's an urgent This is urgent call to action. So, and in Babcock University, my team and I, we've been working on AMR for some time. That's antimicrobial stewardship. And then being a clinical microbiologist, I'm also excited at your uh, that aspect of your presentation
Thank you, sir.
that you involve the diagnostic stewardship. Very, very beautiful and
Thank you,
very, very
Prof.
practical. Because
Yeah.
just like you have said, if you diagnose the right pathogen, then there will be no presumption over which antibiotics to use. Get the right pathogen, you get the right antibiotics, and then problem of resistance will be on the downfall. So, and like we've been telling our students, antibiotic is the only type of drug that misused by one person can actually trigger a doom for the entire country or for the entire world.
Yeah.
So that is because the resistance strain in one patient can be transmitted to others. So then to wrap up, my important point now, I love the that's your final slide, the last part that you said advocacy beyond advocacy must go beyond the
Bedside.
bedside. Yes. So we love that. We we are currently working on some grants, and I also want to call on you. I don't know much about your detail, but later I believe my people will tell me more about you. I would love to have your contact and that your organization, if there's a way you can also, because for you to have accepted uh, this time to talk to our uh, amiable doctors to be doctors in training on this all important subject. If you're any way your organization can collaborate with us, that we can do some community-based projects on antimicrobial stewardship that will involve students. I believe this antimicrobial club of Babcock University is the best partner you can have. And you know the role of youth, you know what we are saying. This young generation, they can take the message. And we need a generation that will be equipped with the right knowledge, right mentality for antibiotic resistance to be on the downward trend. It's just like that advert. I love it so much about the HIV that let's create a generation that will be HIV free. So we also need a generation that will have the right knowledge, whereby our people will no longer be the one pressuring their doctor to prescribe antibiotics when they don't even need antibiotics. So I would really love it to talk more with you. And if your club, I mean your organization can partner with us, especially with the AMR Club,
Yeah.
I can speak for them.
No worries,
They are
Prof.
ready. These are
Yeah.
group of zealous, passionate youths. Thank you very much. God bless you.
Thank you so much, Prof. I want to say I'm very grateful, and it's rare. It's rare most times, to see incredible individuals like you being very, very intentional about the growth and development of the younger ones. You decided to join the call, and I'm happy that you are here. And thank you so much for the wonderful comment as well. Um, Based on your request, currently, I am now with the with Texas Tech University here in Texas, in the United States, where I'm doing my PhD in One Health Sciences. Before coming over here, I work with the Global Health Network at the University of Oxford. I'm no longer with them, but I am still in touch. I can reach out and I can actually connect, the executives or signpost opportunities. There are opportunities that I feel um, the team here can take advantage of. Maybe there are opportunities for research collaboration or opportunities for connection to tools, resources, training materials, and all of that to help this team build the required capacity to be able to ward off the impending danger of antimicrobial resistance, I gladly would do that. And over here too in the United States, if I come across opportunities, I've been doing that before, and I'm very confident that Emmanuel can confirm, and Lawrence can also confirm as well, that when I have stuff like this, I share with them. I am very, very passionate about, youth involvement in the issue of antimicrobial resistance. And I really want to see them take the stage, becoming a leading voice, in the issue of drug-resistant bacterial infection and antimicrobial stewardship and all of that. So you have my commitment, you have my words. I'll be happy to. And if I see anything, I will share. And if you have any area that you feel my talent and skills will be necessary, feel free to let me know. As as a PhD student now, I don't have 100% authority about my collaboration yet up until I'm done. So sometimes I might have to get approval from my advisor and let him know I want to collaborate with these people here, and here is what they are doing, and this is how it aligns with my area of interest. And if I get the go ahead, gladly, I'll be happy to work with your team. And maybe the request comes when I'm done with my PhD program. Of course, then I am now an independent researcher. I can gladly, sign up and join you, and we can do stuff together. So thank you, Prof, for the opportunity, and I'm very, very grateful for that.
Thank you, Godwin. Thank you. So I'll get your contact from OJ. Thank you. God bless.
Thank you so much, sir. It's been an honor. We are very, very grateful. Thank you, Professor. Thank you, Mr. Godwin. We are really, really grateful. We are honored, and it's just been a wonderful time. Thank you so much, sir. We're also grateful for the opportunity to collaborate with you, Mr. Godwin, and we'll be open. We are very open to work on future projects. I want to say thank you to everyone who joined the call. If you have any questions, please don't forget to ask them. You can send them to the group as well if you don't want to share them here. I wanted to say something, but Professor Eliku has already mentioned it, where patients will pressure their doctors to push drugs, give them antimicrobials, antibiotics, and doctors who, for example, in LMITs here, who might be lacking on the financial aspect, will be pressured to giving them antibiotics, even though they don't need it. But he has already mentioned it, and one way by which we can combat that is through education and provoking positive behavioral change. So that is such a wonderful thing to work towards. Thank you so much, everyone, for joining this call. It's been a great time. Thank you so much, Mr. Godwin. Thank you, Professor Eliku. And with this, we'll round up the call with a closing prayer. So, our Father in heaven, we say thank you for this call. Thank you for helping us to this point. Thank you for how much we have learned. Thank you for how far you have impacted us. Thank you for the promises of a wonderful collaboration together, a better future where we can be better stewards of antimicrobials and even possibly AMR free. Father, we ask for this grace that you grant unto us the grace and wisdom to work towards that future with more passion and with motivation and with energy and discipline. Receive our thanksgiving in Jesus' name. In Jesus' name we have prayed. So have a wonderful time, everyone. We'll be clocking out now. Good night.